So you've heard two very wonderful uh, bench presentations this morning about some of the basic science related to CF dealing with infection and inflammation. And now we're going to switch completely from the bench to the bedside or the clinic. My talk's going to be completely clinical, and I hope highly relevant to people with CF, their families, as well as people who are taking care of them. I've titled it "Aging in the New Age of CF" because we have arrived in a new age. Um, I saw my first CF patient as a pediatric intern at Children's Memorial Hospital in Chicago in 1975. And I have to tell you, thinking back on that experience, my main emotion was fear and reluctance to even deal with the patients because these were children before pre-adolescence that were in the hospital with severe exacerbations, end-stage lung disease. We knew that CF was a genetic disease, transmitted in an autosomal recessive fashion, but we didn't have the faintest clue as to what CF really was. And it wasn't really until the 90s that broke open with the genetics and the understanding of CFTR function. So we fast forward then to today, and I want to give you a snapshot of where we are today as a sort of a preview as to where we'll be going. So what you see here on this first slide are some selected data from the registry. Now, the CF Foundation registry was established back in the early 80s, I believe, due in large part to the efforts of a wonderful woman named Stacy Fitzsimmons at the foundation at the time. And today is an extremely powerful tool to understand the epidemiology as well as improving the care for patients with CF. And what you see here is a realization over the last 20 years of the tremendous improvement in lung function that we see in patients with CF, where the average FEV1 20 years ago was 80% predicted and now is firmly in the normal range in the 90s. And the proportion of patients who are surviving now to adult age has improved tremendously. In addition, you see a change in the demographics of the disease, which is very important for understanding therapy, because what we now realize is that CF is a universal human disease. It's seen in all ethnicities in all parts of the globe. And when I was training and for many years afterwards, there was a sort of a dogma that this was a Caucasian disease. We didn't need to worry about it if you weren't of European descent. And we know that's now not true. And it has very important biological implications because the type of cystic fibrosis, the phenotype, is dependent upon the genotype. And patients from non-European populations have tremendously different array of mutations causing their cystic fibrosis, and that has important implications for the actions of the modifiers. As lung function has improved in patients with CF, we see a tremendous drop in the need for transplantation in patients, and we see a change in the lifestyle of patients where, for example, pregnancy is now something that's fairly common and was unheard of 20 years ago, almost unheard of 20 years ago. So these tremendous demographic changes have presented us with a new type of picture of cystic fibrosis in 2024. In 2019, Trikafta was introduced in the United States through FDA approval after a phase 3 process, which it's important to recognize did not involve all patients, all types of patients with CF. Most of the patients who are in those clinical trials were of European descent in the United States. And almost all of them had lung functions that were in the moderate to mild range rather than severe range. And that has implications for the use of these drugs. So you see the introduction of elixacaftor here with ETI, which is Trikafta, the three drugs together. I'll be calling them ETI. And that's given rise to a phrase that clinicians are using these days called highly effective modulator therapy. And it's called highly effective modulator therapy because of the effects that are seen in the demographics. It's also important to realize, though, that ivacaftor, which has been around and approved since 2012, we started doing clinical trials back in 2009 and 10 on this drug, is also highly effective modulator therapy for the 4 to 5% of patients that have gating mutations. So together, these two drugs for their particular target populations consist of what we call highly effective modulator therapy. And it's tempting to think of this as something that controls cystic fibrosis, but you've already heard this morning from the preceding talk that inflammation is in fact not completely curbed. We know it's persisting, and we also know that infection, while modified, is also persisting in patients on highly effective modulator therapy. So it's clear just from that information that this is not a complete control of cystic fibrosis. It's certainly a giant step forward. So the current hallmark of cystic fibrosis, I think, has two characteristics. One is the aging population. You see here the relative contributions of the pediatric population and the adult population. And we see that the pediatric population is relatively constant as new patients are diagnosed and older patients move into adult life, with a steadily increasing proportion of people that are adults. And when you break down to what these represent, you see the increasing diversity represented by the greater proportions of non-European descent populations, particularly the Hispanic population, increasingly the African American population, and most recently, we are beginning to appreciate the prevalence of cystic fibrosis in other parts of the world, including South Asia, the Far East, and the Global South. And I'll come back to that a little bit later. The information in the CF registry, Foundation registry, of course, refers to patients in the United States, doesn't include people in Canada or EU or any other part of the world. A recent publication in the European Respiratory Journal from the European Cystic Fibrosis Society and their own registry shows very similar kinds of information. What you see here is a graph of lung function in succeeding years as a function of age, and you can see that there is a steady upward movement of the FEV1 as time goes by, with a bit of a gap here in the latest data that indicates the emerging impact of Trikafta or its equivalent in the EU and the approved countries. So I mentioned that in the clinical trials that led to the licensing of Trikafta, the patient population is not a universal sample of cystic fibrosis, excluding certain ethnicities who are underrepresented in clinical trials for a variety of reasons, and also patients with severe disease who are excluded from the selection criteria. So one of the important things to look at, first of all, is the drug as effective in severely affected patients as it is in mild or moderately affected patients using lung function criteria. And an example of the kind of data that we can see when we look at this is from this study that was done in France on a multi-center basis in several hundred, 400 plus patients with CF who had baseline FEV1 percent predicted below 40%. That is, they were ineligible for treatment with Trikafta in the approval process in the United States and in other countries where Trikafta is going through an approval process by clinical trial. What you see here on the left side of the panel are the lung function results. And the sort of the take-home message here is that the magnitude of the improvement in FEV1 that we see with these severely affected patients is actually quite similar to that seen in mildly affected or moderately affected patients of older age and also in children when we can reliably measure their lung function by spirometry from about age 6 and up. And that fact is very heartening, but there is also an age effect in terms of the fact that the improvement is somewhat less in older patients, particularly those over the age of 40 when they initiate therapy, to those that are younger. On the upper right, you see a series of panels about the nutritional effects of Trikafta in this severely affected group. And again, the response in terms of weight and body mass index is basically equivalent to what we see in more mildly affected patients that went through the approval process. And then finally, in the bottom right, you see here some clinical measures that are very important to quality of life, namely, of course, the use of IV antibiotics and hospitalization, comparing the year before initiation to the response to initiation as time goes by. And we see a very dramatic impact in the use of these antibiotics and hospitalizations, even in this severely affected population. So that's the good news, that ETI in particular, and I think very similar data have just been published for ivacaftor and gating mutations. They're very effective in all levels of severity. In fact, many of us have heard stories about people that were on the transplant list and could be taken off the transplant list because of their response to highly effective modulator therapy. So that all sounds rosy and wonderful. In addition, we actually have modeling data which goes beyond the actual available information to give us sort of predictive numbers. And this was a study that's been cited a lot recently in the last year or two that came mainly out of the statistical work from Vertex with some help from a collaborator in England, showing the predicted effect of ETI on survival. And what you see here is a comparison of the ETI effect to older modulators like Orkambi and Symdeko. And what you see then is a tremendous improvement in predicted survival using a model that is called person-level microsimulation, which is a statistical method. So this is not actual human data. This is a statistical prediction, but that's the same kind of statistical predictions that are driving climate science and various other clinical scenarios for the effect of new therapies on various diseases. And this is in a population that was selected to be a homozygous F508del. So the majority of patients in America would fall into that group. And it compares the survival to the overall survival in the non-CF population. So we see it's improving here up to about 70 years of age, which means that we can actually expect that most people with CF on Trikafta can expect to have normal lifespan, close to normal lifespans. There's a bit of a complication to this, or a complexity to this, because if you look at the age of initiation, that has an important effect on the length of survival predicted. So in the yellow bar on the right here for each group, you see the predicted survival without any modulator usage. And then the middle two bars are the older modulators and Trikafta in the red bars on the left. And you can see here that with initiation starting in adolescence before the adult life, the actual predicted survival is now pushed into the low 80s, which is basically normal survival. If the drug is started later in life, of course, you don't do as well because of the impact of prior disease prior to the initiation of therapy. So those are all extremely optimistic predictors of what CF is going to look like, not only today, but going into the future, based on what we have available. Now, I should also mention that no later than January 2nd of 2025, the FDA will make a ruling on a submission for a once-a-day triple combination of vanzacaftor, tezacaftor, and deuterocaftor. So two new modulators combined with tezacaftor, which is in the existing modulators. And the clinical data from the phase 3 trials that have been conducted that has led to the new drug submission for this new triple show that in terms of lung function, it appears to be non-inferior to Trikafta. And in terms of the effect on sweat chloride, it actually appears to be superior, especially in younger age patients. So we don't know yet if this is actually going to be clinically more beneficial than Trikafta, but we'll certainly find that out in the coming several years as this is carefully evaluated. So far, everything is looking very good, but what are the problems? What are the challenges? It's already clear that if you start ETI or if you're on ivacaftor for a gating mutation as a highly effective modulator therapy, your CF doesn't not only go away, but you continue to have a lot of troublesome issues in your life. And this is a study that was done in Emory of over 260 patients. The important thing to notice here, this is a recent study, and almost 4 out of 5 of these patients were on highly effective modulator therapy. And then they received a questionnaire about their symptoms and the level of distress caused by those symptoms, which are shown here. So in the blue bars, you see the prevalence of these reported symptoms, starting with low energy and cough, which are present in over 80% of the patients. So they're still having symptoms related to lung disease and also general, if you will, malaise in some ways. And then several other very important symptoms and problems in a substantial number of patients, in many cases, the majority. One of the most important that it also coincides with the highest level of distress, which is indicated here by the black line, is in sleep disorders. And this is something that has not been emphasized a lot heretofore in practice in CF care or among the patient community, but I think has now come to the fore as a significant issue, certainly appears here. So the second most troublesome one is chronic pain. And in fact, we also have a study, I don't show the data from, but it's from Australia, which indicates that chronic pain was present in a quarter of their patients on highly effective therapy. So we have the persistence of many problems that cause distress and discomfort to patients. Maybe not a life-threatening thing, but certainly something that affects quality of life, and that's important to try and deal with. The second issue, besides the persistence of symptoms and problems that I'd like to point out, is that like any other drug, ETI is not equally effective in every person that receives it. So we've known this for ages in drug therapy, that you have typically a bell-shaped curve of response. You have a lot of people in the middle. You have some people that respond remarkably, and you have a tail of people that don't do as well. So how can we quantify that and get some handle on the likelihood of a response? And that's indicated here in this particular study, which comes from Milan, Italy recently. And what they did was to use a number of cutoff values, which are shown here on the right, to distinguish a subgroup that's not responding well. So, for example, in the area of lung function, they would define a person that did not have at least a 2.5-point improvement in percent predicted FEV1 as a low responder. And then they said, well, what's the proportion of the patients in our clinic in this study that meet that criteria, therefore a low lung responders? And if you look at that, it's about 20% of the patients. And then they also looked at other areas such as the sweat chloride response, the nutritional response, and the overall quality of life response as measured by the CFQR, which is the sort of standard quality of life measure used in CF, looking at the respiratory domain. And the interesting thing here is that we have basically fairly non-overlapping subgroups of patients that are not responding that well. They all go in at about 20 to 25% of the total. So it's a significant minority of patients that, even though we have ETI in our pockets and available, they're not going to do that as well as the majority of patients who are responding very well. And that's important to recognize this heterogeneity. And we don't yet know if the once a day, for example, that's going to probably be here next year, is going to be able to alleviate that problem in patients that are not responding as well to ETI. So let me turn now from the particular effect of modulators and how that's changed everything to what we can look forward to in terms of dealing with complications, some of which are old complications, in a new phase, and some of which are truly new complications that result from the combination of living with CF and growing older. This is just a cartoon that sort of summarizes some of the areas. I'm not going to be speaking about all of them, but some of them. So diabetes is certainly one. Cancer is another. Bone disease is a third. Somewhat unexpectedly, cardiovascular disease now emerging also, and something that we do know about pre-modulators, but is certainly not solved by modulators, issues of mental health, emotional health with anxiety and depression in particular. And finally, obesity has also been mentioned even today as new complications resulting from the correction of nutritional problems. So first about diabetes. It's not that this is a new problem, but it is an age-related problem that becomes more apparent the older you get. So on the left-hand side, we see the prevalence of CF-related diabetes as a function of age. And you can see here that by the age of middle age, half of people with CF are going to be dealing with diabetes. This is not just glucose intolerance or asymptomatic disease. This is diabetes that needs treatment with insulin. On the right-hand side is a nice cartoon about the pathophysiology of CF-related diabetes, which emphasizes the fact that it's not type 1 diabetes, juvenile diabetes so-called, and it's not type 2 diabetes that the general population is familiar with. It's its own brew. And the reason for that is shown here by the list of potential factors that either cause or worsen diabetes in people with CF as opposed to non-CF. And that's cartooned here in these boxes. So what you see here is a mix of the problem of insulin secretion and insulin resistance. Some diabetes being caused by the lack of insulin secretion. This is juvenile type diabetes. And it's important in the beginning as the main component of CF-related diabetes. And then as time goes on, we see more and more insulin resistance. That is the lack of response of the cells to insulin when it's present, let's say after a meal. So this is the typical type 2 diabetes that the general population is in epidemic form suffering from, not only the US, but in most of the world these days, as general health has improved and nutrition has improved globally. And then in CF, we also have a third component, which is the fact that during an exacerbation or serious infection, there is also a worsening of glucose metabolism. So typically during an exacerbation, patients will have higher glucose levels, and this may persist for some time and may need specific therapy. As time goes by and patients get older, which we're going to see, as you see here, and also from the predictions with the effect of the modulators, we see more and more diabetes and more of a likely contribution of insulin resistance. So in addition to the use of insulin, which is sort of the gold standard and used now for CF diabetes, we may start to see more need for type 2 type drugs, which are available, which are oral drugs in the treatment of some component of older CF type diabetes. But these studies need to be conducted as the patients' cohorts age further, and we see the impact of differentiating insulin secretion or insulin deficiency from insulin resistance. Those data need to be developed over future studies. The other thing I'll mention about diabetes is gradual change in monitoring and diagnosing diabetes in CF. There's been a gradual movement away from the glucose tolerance test to something called continuous glucose monitoring, which you may be familiar with as a more precise measure. That's not yet resulted in a change in general guidelines, but more and more practitioners are doing that, particularly as we get further input from diabetic endocrinologists in how to diagnose and manage diabetes. So this is going to be an increasingly important part of CF management in the years to come. The second complication that I want to delve into a little bit more is cancer. And on the left-hand side of this slide, you see a diagram that is entirely speculative. What is the relationship between CFTR dysfunction and cancer? There are a lot of hypotheses floating around about what this relationship may be. We've already seen how CFTR affects multiple cell functions in the immune system, the inflammatory system, and other metabolic systems that are less talked about but are relevant. And there probably are interactions between CFTR and the signaling of various metabolic processes in the cell that may affect the propensity to cancer. Certainly, inflammation is playing a role in at least the GI tract, we think, contributing to the issue. And on the right-hand side of this slide, you see a list of different types of cancer and risk levels that have been estimated for people with CF as opposed to non-CF populations. The one that's gotten the most attention, of course, is intestinal, particularly colorectal cancer, with an estimated relative risk of about 6 in people overall with cystic fibrosis as compared to the non-CF population. But if you've been transplanted, that risk skyrockets to 25 to 30-fold over normal. Elsewhere in the GI tract, we also see definite indications of probable increased risk for pancreatic cancer. That's been pretty well established, and also less well established esophageal cancer and upper GI issues like stomach cancer and small bowel. But these are all things that need to be kept in mind. And then there are a bunch of other potential sites that also probably do represent increased risk. Some recent data in breast cancer indicates increased risk among women with cystic fibrosis compared to controls. So as I mentioned, intestinal cancer, and particularly colorectal cancer, has emerged as the most worrisome. There was an expert panel that was convened by the foundation and recommended changing or initiation of guidelines that were published in 2018. So it's already been about 6 years since those guidelines came out, which recommended more aggressive screening for people with CF against colorectal cancer compared to others. On the right-hand side, you see a graph which shows the data that's behind this kind of recommendation. So we have the prevalence of colorectal cancer in CF patients in the registry compared to a non-CF general population risk rate here. And what you see that as early as the mid-30s, there's a clear differentiation between the CF and non-CF, and it certainly takes off after the age of 40. It gets progressively worse as age increases, leading to these recommendations for non-transplanted patients to start getting colonoscopy at age 40 with a 5-year repeat, unless polyps are found, and which then every 2 to 3 years follow-up colonoscopies, which is a pretty aggressive monitoring regimen. Yes, there are alternative ways to screen for colorectal cancer, but they're not as accurate as colonoscopy, and this is the recommended procedure. For people that have been transplanted, the recommendation to start screening at age 30 and repeating in the same way, but starting within 2 years of the transplant if below age 30. And then something that's not so much emphasized, the fact that the PrEP is different for people with CF. It's unfortunately got to be more aggressive than the normal PrEP. So this is one of the more unpleasant things about dealing with this as a screening test, but it's something that needs to be done. And what about cardiovascular disease? This is a cartoon that looks at the risk of atherosclerotic heart disease in the general population on the left-hand side here. So age itself, of course, is one factor: hypertension, smoking, obesity, diabetes, family history, lipid disorders of various kinds. These all contribute to atherosclerotic heart disease, which is the thickening of the blood vessels with these fatty plaques that can occlude or block the coronary arteries and cause a heart attack. On the right-hand side, we see some issues related to CF-specific problems that may contribute to further risk of cardiovascular disease in people with cystic fibrosis. which you see listed there. And this just pertains to the atherosclerotic portion of heart disease. There's also another huge chunk of cardiovascular disease, which is related to conduction or rhythm disorders, right? What's the actual data? So this is an interesting study that looked at a large number of people with cystic fibrosis using a registry similar to what we have here, maybe not quite as extensive, that's used in the UK, and comparing them to a general population database to look at relative risk. And what you see here, the dividing line of the relative risk of 1 is anything to the right would be an increased risk. And if the 95% confidence level does not cross this line, that's statistically significant. So in this particular study, they did an unadjusted comparison of the risk and then also an adjusted comparison. And to adjust the comparison, you use a scheme called a propensity scores, which match for particular inputs that take them out as confounding factors. And this is something that's been used very successfully in CF. We've done it for a number of years with the modulators to look at the effect of modulators on the rate of decline, comparing people on and off therapy using propensity scoring to take out confounding factors. So in both analyses, both unadjusted and adjusted, we see a very significant relative risk of around 2, twice as likely in people with CF compared to non-CF for what are called major adverse cardiac events. And those are defined as these 3 components below, basically myocardial infarction or heart attacks, heart failure, and atrial fibrillation, which is the most common serious rhythm dysfunction that occurs in people, and is basically usually unrelated to atherosclerotic heart disease. What you see here is a highly elevated risk for both MIs, heart attacks, and for atrial fibrillation. With the adjusted analysis, the heart failure risk goes down a little bit, and then taking out the confounding factors, it's no longer statistically significant. But this is something we've known about for decades in CF. Heart failure is in itself somewhat complicated. In most people, it is caused by failure of the left heart, pumping blood to the body. In CF, by history, traditionally, it's been more of a right heart failure problem from increased resistance to blood flow into the lungs as a consequence of the lung disease that's called cor pulmonale, something we don't really see in CF these days, but may be contributing to this unadjusted risk factor. So the bottom line here is that yes, heart disease does occur in older people with CF at a higher rate than it occurs in people without CF. And therefore, in the care of adults and aging people with CF, we're going to need to develop the expertise to screen for and treat heart disease and cystic fibrosis. The third area that's of concern is, again, something that's historically been recognized, which is osteopenia and osteoporosis, weakening of bones, loss of bone mass. In people with CF, there are a number of possible contributing factors, which are shown there on the left. Most of them have to do with increased loss of bone due to infects, probably secondary to inflammation. But on the right-hand side, you also see some interesting data that's emerged from studies in recent years that indicate that CFTR does have direct effects on bone formation and destruction, and basically has some inhibitory effect on bone formation and less so in bone resorption, but this is where the inflammatory factors play more of a role in increasing bone resorption. The net result of this is that people with CF have to be aware of the fact that their bones may be affected and they may become more vulnerable to pathologic fractures, which obviously can cause disability and pain. Another area that's important, and I don't want to go into any detail on this because you're going to hear a really nice talk this later today, I believe, on reproductive health issues in CF, just listing here a variety of things that used to not be much concern because of male infertility, female subfertility, and the overall survival issues and reluctance to engage in becoming a parent with CF, That's now been allayed to a large degree. We still have problems of puberty, delayed puberty in some cases, newer problems in terms of recognizing gender identity issues, dealing with contraception and family planning in folks with CF, avoiding sexually transmitted diseases, treating subfertility and hypogonadism, which is still something that needs to be dealt with in many patients, and the increasing use of assisted reproductive technologies, especially for men with CF to be able to be biological fathers. Pregnancy is something that we used to advise against in many patients, and nowadays that concern has generally been abolished, so full speed ahead. But we still have to recognize that CF pregnancies are high-risk pregnancies, require specific obstetrical expertise during the management of the pregnancy, labor, and delivery. Breastfeeding is, again, a newish problem because now when you have a child, an infant with CF, breastfeeding is certainly an option, but what about the effect of modulators on the infant or other drugs that mom may be taking that get into breast milk? So those things need to be dealt with on a fairly expert basis also. The whole general issue of parenting, a newer issue that is age-related is pelvic health, in particular urinary incontinence, a very troublesome symptoms if you develop that. And then many new issues around menopause, which are troublesome to many women as they age, that need to be considered in going forward with the care of folks with cystic fibrosis. So hopefully we'll hear a lot more about this afternoon. Another area that has not gone away has been the recognition of emotional well-being, mental health, and the prevalence of anxiety and depression, not only in CF patients, but in their caregivers and loved ones, which is naturally to be anticipated dealing with a serious illness like this. Over the last decade or so, largely due to work by Alexandra Quittner, but many others as well, we've been able to recognize that there are very simple, easy tools that allow us to both diagnose anxiety and or depression and stratify the severity of that by using these simple tools, which can be administered in clinic. And most clinics have now adopted this as an annual screen with treatment algorithms now pretty well worked out for follow-up of patients that have anxiety or depression issues, which may require counseling or even drug therapy to deal with. This is not going to go away, I don't think. In addition, there is a lingering concern about the effect of modulators on the central nervous system. CFTR is expressed in certain parts of the brain and may well have some direct effect on neurocognitive function. And although a recent study using the registry did not show elevated risks for anxiety or depression overall with the use of ETI, there's still concern that with some sub portion of patients, there may be negative effects. And there are many anecdotes about this in case series. We just don't have a good handle yet on picking this up in terms of any predictive way to know whether that's going to be effects. But it's something that needs to be monitored with the initiation and use of modulator therapy. And I think we'll probably see more information about that as people look at this more closely, especially as new generation modulators come into the clinic, as we expect to occur as early as next year and probably more thereafter from other sources. So there's been the generation of a number of approaches to deal with these problems outside the lungs in terms of various ways to monitor and detect. So for example, for bone disease, there are now guidelines in terms of when to start using DEXA scans, which is a way of looking at bone mass quantitatively. There are other methods also. And when to start and when to repeat these tests that can lead to intervention, nutritional or drug therapy, which can be helpful. And that applies to many of the complications that I've been talking about. For diabetes, earlier testing, we still don't know exactly the optimal time to start insulin therapy. Will things go better if we start earlier than fully diagnose CF diabetes? If there's a certain level of glucose intolerance, will those people do better over time if they start therapy earlier? What might be the effect of type 2 oral drugs, particularly in older patients and so on? So there's a lot to be learned in that area. So I'm going to turn now from the complications to the interaction of the person and family of the patient with the system, which is a very important aspect to the outcome. So the structure of the care model is changing as the demographics of the patients change. We're all used to the core team, your CF doc, your nurse coordinator, the respiratory therapist, the dietitian, the social worker, psychologist. But we now have the addition of our expert consultants and those that are going to help out. And one example of this, of course, is the diabetologist, because most CF docs are pulmonologists, some are gastroenterologists, the vast majority are pulmonologists, and we're not expert in the care of diabetes, particularly as something as complicated as CF diabetes. So we need help from our endocrine colleagues, and even within endocrinology, having CF particular expertise is by no means universal. We have to find those people that are interested, well-trained, and really know how to deal with CF diabetes to obtain an optimal outcome. So the current model has the core team interacting ever more closely with these consultants and helpers, both physicians, physician assistants, and others, in terms of making sure that the patient's needs are being addressed properly. The elements of the CF care are very complex. And so you see here the details of this. In many of these cases, the guidelines and the recommendations for the expert treatment of each area are published. And hopefully when this document comes out, you'll be able to go to the particular reference, which is indicated by its assignation in the Public Library of Medicine that's on PubMed. What most folks with CF understand about the medical system comes from your clinic visit. And if you're unfortunate enough to be in the hospital with the providers in the hospital. But it's important to recognize that this is a very complicated area within medical care because of the multi-system nature of CF and the changing demographics. We have, besides the medical interactions that occur directly between the care center and the person, your lab tests, your clinic visits, your results, your questions, your phone calls, the daily reports if you're in the hospital, whatever it might be. There's also these administrative and financial components to the care system. So on the administrative side, it's important to remember that most CF centers are existing in relationship to large healthcare organizations, which don't necessarily have a focus on CF or other chronic diseases, which are often not highly remunerative to the institution. So the care center has to navigate its structure, has to navigate its function, its budget within this complex institutional framework. And it's important to try and partner up with your care center to be effective advocates. Certainly in the institution that I've spent my career at, Stanford, without community members helping in interacting with the administration, both at Lucile Packard's and at Stanford University Hospital, we would never have gotten the resources that are really necessary. And many centers are both underfunded and understaffed because of their position in the medical hierarchy between other areas that bring in a lot of money to the institution. That's just the way it is within our system. From the patient viewpoint, it's also to understand, important to remember that there is a program that the federal government has set up for help with outpatient costs of certain drugs. It's a restricted formulary, but there are some important CF related drugs that can be helped by participation in this program, such as omeprazole and insulin. So it's important to check with your center about whether or not they're able to provide those kinds of resources that supplement other sources of coverage and reimbursement or reduction of cost for treatment. So it's a complex machine that's going on there, both in terms of the direct interaction that you as a patient or family may have, and also what's happening internally within that care center in terms of whether they're able to perform as well as you would like them to perform. And partnering up and helping out is, in my experience, is actually more effective than the people inside the organization. You can exert more positive pressure than we can inside. So I mentioned this relationship to these people outside the core team that are going to play an ever increasing and important role. On the left-hand side, you see data from the registry showing major complications. And besides some of the ones I mentioned, there are others like asthma, sinus problems, and reflux, which are very highly prevalent in the adult population with CF that are, I think, going to be ongoing concerns. So expert care, for example, if you have a reflux problem that's properly diagnosed, it needs proper treatment, and it's likely that you're going to need to interact with an adult gastroenterologist to get the care that you need, helping out the primary CF physician and team providing that care. So whether that occurs within the CF clinic visit itself or through technology remotely or through direct visits to other subspecialties, these are all going to be elements of CF care increasingly as we move forward in the future. And this on the right-hand side is a list of the types of subspecialists that are going to be needed increasingly to deal with these age-related problems. So the cardiologist for cardiovascular disease, the endocrinologist for your diabetes problems, and so on and so on. If you have problems with your joints, CF arthritis is a recognized problem, and it probably is going to need the help of a rheumatologist to get the right kind of therapy. So it's going to get more complicated even as you live longer to deal with the sort of panoply of non-pulmonary life-determining problems related to cystic fibrosis. And then the shift is going to be away from the lung problems to some degree and more towards these wide variety of other problems that are not going to go away until we have a real cure for the disease. And that's one important reason to pursue that research, to get fundamental therapy, hopefully a one-shot deal as the ultimate cure ultimately. The other thing that I think is very impactful and strongly related to the COVID pandemic has been the impact of remote medicine over these last few years, as people have been reluctant to come into clinic and having to go through some of the hassles related to infection control that have changed with the impact of COVID. So increasing use of remote technology for care and how this impacts the outcome as well as the process. So some examples of this are given here. Take one example of home spirometry. We now have the ability to do pretty accurate home spirometry testing and transmission of those results electronically, so that it's no longer as necessary to come in and do spirometry in the clinic. We still don't have nailed down the relative accuracy of home spirometry versus clinic spirometry, but it's getting better and better. And that's something that more and more people are doing. We've looked at the potential to use home spirometry as a predictor of exacerbation or as a reflection of outcome. Those data are still somewhat shaky, in my opinion, but we can expect more and more of this. And another similar example would be the sputum problem. So people that used to bring up a lot of sputum, they're dry now. You know, ETI, you're not coughing. You may still cough, but you're not getting anything up. What are we going to do about that in terms of monitoring the infection problem? It turns out that there are methods to produce more sputum at home, either by enlarging the time period for the collection or use of some stimulant like hypertonic saline to try and get some sputum raised. Then you have the issue of, okay, I've got the sputum in the cup. What do I do with it? How soon does it need to go? How do I ship it? How accurate is that result going to be once it gets to the micro lab for analysis? All those factors have to be worked on. So this whole area of using remote technologies to help care for people without needing to come into the clinic center or be hospitalized is something that's going to accelerate, if anything, over the coming years. In terms of the interaction between the caregiver and the family and the patient, we of course have the rise of telemedicine. Sometimes we take for granted how fantastic video conferencing has become since COVID. Zoom was a word I'd never heard of before 2020. And then suddenly everyone in the world is using Zoom. Of course, there are other companies that provide other very good platforms. But what does telemedicine do to the outcome? Can you stop coming in quarterly? Can you just come in once a year if you're on ETI and doing okay? Well, we don't have a firm answer to that. That needs to be studied. And there's certainly a lot of advantages, extreme advantages. There are also some disadvantages, not least of which is the income issue. I already mentioned the problems that CF centers may have in terms of staffing and labor time and other things that are needed to adequately take care of patients. But the income from a telemedicine visit is much less than the income from an in-person visit. And that's just one aspect. What about the actual medical issue? Someone looking at you on a screen is not someone examining you and laying on of hands and really getting a feel from the interaction of two bodies dealing with each other, two humans dealing with each other. So we still don't know exactly how this is going to play out, and it's a rich area for future research that I think hopefully we'll get some answers to. Another way to try to deal with this issue is to focus on vulnerable subgroups instead of focusing the same approach for everyone. Try and delineate some particular issues. For example, the transition period of late adolescence, early young adulthood. To me, this is the most troubling time in CF when that transition is occurring in terms of what's happening within the life of the person, but also in their relationship to their professional caregiver. It's going to change from a pediatrician to an internist. And that can provide some profound differences in approach to care. So monitoring particular subgroups in a specific way is, I think, something that we're going to see more and more of. For example, in our clinic, we have a particular attention to newborn screening. So a particular caregiver is attached to that newborn early screened patient visit to get them initiated into the center and get care going early. Let me close with some observations about how care is distributed to CF in the world. We're all used to thinking nationally. We have the CF Foundation Registry, we have CF Care Centers, the United States, they're different in Canada, they're different in the EU, they're different in other parts of the world, they don't exist in most parts of the world. How does this affect things? Well, one way that's, I think, critically important is the lack of diagnosis. CF diagnosis is now quite good in North America, in the most countries in the EU, not all, and in Australia and New Zealand, through the development of widespread sweat chloride testing held to high standards, as well as the widespread availability for genotyping and even newborn screening in most of these areas. It's not the case in most of the world. So it's only a minority of the human population that has access to proper diagnosis of CF. And we see here this particular study, which looks at, based primarily on some localized genotyping assays in various places, what the actual numbers of undiagnosed people with CF might be. I'll just draw your attention to the case of India and Pakistan, South Asia, where although there are about 600 known patients with CF, there may be 50,000 patients based on these early genotype surveys. My own personal view is it's probably closer to 100,000 in South Asia. So almost all CF is not being diagnosed in places where it's quite prevalent. And there are now even studies coming out from China indicating that, in fact, CF not only occurs in East Asian folks, Chinese folks, Han Chinese ethnicity, but is almost always unrecognized because of a different set of mutations and a different phenotype. This is all stuff that's going to be coming out more and more as CF globalizes, as we realize this is a disease of humanity. It's not a disease of European populations. Following that, we have the development of drugs and approval of drugs based on where the diagnosed patients are. So we see that in North America and the EU, Australia, New Zealand, there's not only diagnosis, but there's treatment. So highly effective modulator therapy with ETI is available in these areas where patients are properly diagnosed and recognized, and their genotypes are known, so the drug can be given where it's effective. But as soon as you get to basically the global south, you see that this falls apart. The people are not being treated because not only are they not being diagnosed, but if they are diagnosed, they have poor access to the drug because it's not been approved in their country. And even if it's approved in their country, there's still an issue of who's going to pay for a $300,000 a year drug in Brazil or South India. This has to be addressed, and the solution is not simple because there are control of the drugs under patenting issues that restrict the use of generics or lookalikes that can bypass the problem of accessibility. So we see here in the areas of the north, we see that CF is diagnosed, recognized, and largely treated. Particularly if you look at the United States, most patients who need ETI do have access to it. As soon as we switch over outside that, we see that virtually nobody is being treated, despite the large number of estimated patients, actually known patients. We still have a minuscule number that have access to treatment, and it's not fair. So overall, there are a number of issues about the people that don't have access to highly effective modulator therapy. The huge one of undiagnosed CF in most of the world, because we don't have the tools or the structure to do that. It's important to remember that some people actually do have intolerance or toxicity from ETI and other modulators. As I mentioned before, it's looking like perhaps a fifth of the patients that do receive the drug may not respond very well to it for a variety of factors, whether they be genetic, environmental, or some other individualized factor. We have that famous 10% left behind of non-responsive mutations. So even if you do have a proper diagnosis and you've been fully genotyped, it turns out that your mutation is ineligible, your set of mutations is ineligible based on lack of effect. In some of these people, these in vitro predictive tests that have been talked about here and elsewhere can provide an answer and help you get access to that drug. Relatively small number of people involved with that. What's really needed is better technologies to treat these folks. And of course, this is a huge area of research now with both genetic approaches by gene therapy or mRNA therapy or gene editing, as well as some interest now in renewed interest in looking at other ways to get chloride secreted out of the cell and bicarbonate out of the cell by using non-CFTR small molecule approaches. Recent trial just started with one of those drugs. Given all that, there's still the lack of modulator access or reimbursement as a barrier to therapy. And sometimes that's due to the drug itself. And other times we have lack of appropriate professional care. That is the lack of trained people, certainly the lack of organized centers, which have been so influential in turning CF around in the North America, particularly, and the western part of the European Union. So how are we, this is my last slide, how are we trying to deal with this issue at CFRI, having become well aware of the changing nature of CF? And one thing that we've initiated that I'm very excited about is the establishment of a fellowship program. The idea is to take internist subspecialists. So if, for example, you've graduated medical school, you've done your internal medicine internship and residency, you're now a cardiology fellow. How can we get you interested in CF and get you to be an agent for change to improve cardiovascular health in older people with CF? Well, the beginning is through education. And what we're trying to do here is to get people who are senior fellows in these subspecialties to come and get further training in cystic fibrosis, particularly focused on the problems of the older patient with CF who's having a problem in their expert area. And we've already gone through our first application process, and we've selected, I think, 17 fellows now who are going to meet with a group of faculty in Denver in November to have a small, sort of informal, intensive experience over a weekend and get further training in CF, which is then going to be supplemented by projects, podcasts, educational opportunities of that sort. So hopefully, one way we're trying to address this emerging gap between knowledge and need is to get better training through our colleagues in internal medicine subspecialties that we know already are impacting cystic fibrosis, and will do more so in the future. So I think I'll quit there and take any questions that you might have. Thank you very much for listening.